Good evening to one and all. We finished till 170, 180 points yesterday. So we'll start from that point today. Thank you for joining me. Hi to all of you. Uh, Welcome back to another class. Today we'll again have an art class for just 1 hour, and then we have our class, doctor's class by Sir. So let's start with colorectal cancer today. I have added some more pictures so that it's easy for you to understand. So colorectal means what? Colon and rectum is being involved. That is where the cancer is happening. It's a type of adenocarcinoma. It's not a squamous cell. It's an adenocarcinoma. Soft tissues are being involved. So it's an adenocarcinoma. It affects more than twice as many as rectal cancer. So clinical manifestations include you'll have certain bowel pattern changes, and then these people might have melena because all that cancer is overgrowth can bleed. So that bleeding is seen in the feces, which looks like melena. Melena is what? Black, tarry, sticky stools. So that's one of the symptoms. Also, they'll have a change in the bowel pattern. They might have some kind of an obstruction, or they might have loose stools, or they might have some kind of constipation. Some might come with a pain. Okay, all these can be symptoms and signs. And diagnosis is you'll do an abdominal and rectal examination. You'll take a biopsy from that area. That's the ultimate diagnosis. That's the standard. And you can also do barium enema to see any kind of a filling defect in the lumen. Or you can also do a cytology smear. Treatment is supportive therapy, which includes chemo, radiation, immunotherapy, depends upon the stage of cancer. Surgery is the primary treatment. Okay. Bowel resection with anastomosis and possible temporary or permanent colostomy or ileostomy can be done. So if you have one particular area where it is involved, it's just in stage 1. So that part of the bubble is removed, and then you do end-to-end anastomosis of the remaining part. But before that, that part has to heal. So what you do, you create a temporary colostomy, or if it's a pretty large area involving cancer involving the large area, then you have to make do with the permanent colostomy. Colostomy, I told you, right? You're getting a part of the bubble outside over the abdominal skin, and you're attaching a colostomy back to it. So these are the parts of the colon. So this is your cecum, this is your ileum. This is your ileum here. This yellow part is your cecum. This is your ascending colon. This is your transverse colon. This is your descending colon. This is your sigmoid colon. And this is your rectum. Sureshanam, it depends trouble soon. Chaka. So the pen is giving me a slight trouble, so I'll not be using it much. As you can see here, this is the colon cancer. Okay, this is your transverse colon here. This is your ascending colon. And that side on, so this is on your right side. So right side, say we're coming to the left side. So first you have your ileum opening into the cecum here. That's the part of your large intestine. And there you have an ileocecal valve. And above the cecum, you have ascending colon. Near that ileocecal junction, you have appendix, okay? And after ascending colon, you have your transverse colon. And then once you come on the left side, there's descending colon, there's sigmoid colon, S-shaped sigmoid colon, rectum and anus. These are your parts of the large intestine. And as I've pointed out here for you all, this is your colon cancer as it is seen on a colonoscopy. You can see a growth here. Okay. So this you can, once you're doing in colonoscopy, you have observed that growth. What you'll do is you'll take a small part for biopsy just to confirm that it is CA colon. This is also one more picture of endoscopy. You can see this overgrowth here, which will bleed on touch. Okay. So coming to hemorrhoids, before I show you these pictures, let's learn what is hemorrhoids. Hemorrhoids is a uh, growth from the venuses. So it's like varicosities. It's not exactly like varicosities. It's like small venous growth coming out of the venous plexus, but it's not arterial. Okay, so you have this line here, you can see this is your dentate line. Above this is your rectum, and below this comes your anus. Okay, any kind of a growth, any kind of a venous plexus growth which grows above this dentate line from the rectal epithelium is called internal hemorrhoid. And anything which grows below this dentate line coming out of the anal aperture, okay, that is your external hemorrhoid. This internal hemorrhoid can actually overgrow and come out as an external hemorrhoid. You might get confused, oh, this might be an external hemorrhoid because you can actually see it with your naked eye. But it may not be because the stalk that is there, which it's hanging, it's coming from the rectal wall. Okay. This is your cross section. This is like a longitudinal section. Just imagine, okay? This is how you'll see external hemorrhoids. These are all like red, painful external hemorrhoids. This is your anal aperture, okay? Under you can see all these external hemorrhoids. And usually internal hemorrhoids are not painful, but the external hemorrhoids are 100% painful. And they bleed, especially when the patient is trying to defecate. They'll bleed, both internal and external. But pain is mostly felt with the external hemorrhoids. After, what is the ultimate treatment you remove? Because that develops a thrombus. It's a venous growth, right? So that area will develop some kind of a thrombus in it because repeated if you're passing, if you're having constipation and you're passing very hard stools, that area is damaged a lot, and that venous plexus can develop a nice thick thrombus, which is very hard. So what you have to do is you have to go to ectomy, you have to remove it off. Thrombectomy, or you also call it as hemorrhoidectomy. After that, that area is all raw. Okay. So what you do sitz bath. SITZ, sitz bath. So you can add iodine to it, or mostly some people add salt, some people add bicarb. This should be done 3 times a day and after every bowel movement. So if the patient has gone use the washroom to defecate, after that again the patient has to do this shits bath. It's like you have bucket full of warm water. If you don't want to add anything, you can just you can tell the patient to just sit in lukewarm water. Okay. Non-bilious projectile. Okay. Coming back to hyperpyloric stenosis, yesterday I told you. So you can see this if you have a baby in front of you, okay, and you're feeding the baby some milk. So whenever the baby takes a little bit of milk, you can see the peristaltic movement, and during that, this olive-shaped mass becomes more prominent in the epigastric or the right hypochondriac region. That's where your pylorus is, right? So it will become more prominent because, and this baby will have a non-bilious vomiting. Non-bilious matlab, it is not greenish or yellowish. If it is dark yellow and green vomiting, that is bilious. I'll show you. There's a picture. Non-bilious is light color, okay, or whatever the baby has had, the baby will vomit it out. So non-bilious because your bile duct is opening in the duodenum, that is below the pylorus but not above the pylorus. Hence, it is non-bilious. This is Shitz SITZ. Okay. This is how you have varied things, like you have attachable ones which you can put it over the commode, but this is mostly how you do it in India. So you have a tub filled with warm water. You can add different things here, and you will tell the patient to sit for at least half an hour. Okay. This is, he's supposed to do this at least 3 times a day or at least after every bowel movement, so that all that feces which gets stuck to that anal area, all that is cleaned up properly. You don't want any kind of infection post hemorrhoidectomy. Hepatic biliary system. I'll just read this para and then I'll show you a picture. So So hepatic biliary system में you have anatomic and physiological review here. So पहले तो what does hepatic biliary system? What does it mean to you? Hepatic means this liver involvement. Biliary means this gallbladder, this bile duct, the cystic duct. Okay, that is what is involved. Okay, so you have liver here. Firstly, liver is the largest gland in the body. It's located in the right upper quadrant. I'll show you how the abdomen is divided into 9 quadrants or 9 parts. So right upper quadrant mein is where you see the liver. It weighs about 1.5 kgs, that's like 1500 grams, and divided into 4 lobes. Lobes are further divided into lobules. Kupffer cells are the phagocytic cells present in the liver. They are the macrophages. They are like the policemen of the liver. Okay. Smallest bile duct called canaliculi are located between these lobules of the liver. Canaliculi, they carry the bile secreted by the hepatocytes to larger bile ducts, which eventually become hepatic ducts. So you have right and left hepatic duct, which combine to form a common hepatic duct. To this, the bile duct or the cystic duct comes and gets attached, forming a common bile duct. This common bile duct, along with the pancreatic duct, drain into the ampulla of Vater in the second part of duodenum. Hepatic duct from liver, cystic duct from gallbladder join to form a common bile duct, which empty bile into the duodenum of the small intestine. So this is abdomen of humans, and it is divided into 9 parts. Okay, this area is where right-sided is where you find your liver. So this is your hypochondriac area. Hypochondriac is like below your diaphragm, or you can say just below your ribs. Okay, you have your ribs here. Okay, this is your rib cage. This end you can see here is your rib cage, and just in between you have your epigastric region where most of you can feel your stomach. Stomach is all here again. Again in the corner, left hypogastrium is where you will find your spleen. This is the basic knowledge. Beach may just around the umbilicus is this umbilical area, and below the umbilicus is the hypogastric area. Okay, then you have uh, right and left lumbars, and then right and left iliac region. Hmm? This is where your liver is situated. You can see it is there on the right sided mostly, and it is extending towards the left side and a little below in the lumbar region. So यहाँ पे just below the liver you have a pear-shaped organ. I'll show you how pear looks like. It's a fruit, and that's a gallbladder. Hmm? So this is the basic thing. If it is dotted, it means it's lying behind. So this is your right hepatic duct and this is your left hepatic duct. Both are joining to form this common hepatic duct. And this is the gallbladder, and this gallbladder is having a duct called cystic duct which is opening into this common hepatic duct, and all this form a common bile duct. This common bile duct, yeah, इसके साथ साथ this pancreas is also having a duct here and it is opening here, and both this combine and open into the ampulla of Vater. This is your duodenum. This is the basic anatomy of the hepatic biliary system. Now coming to general adaptation syndrome. Yesterday we had small review. It's a little complicated for everyone to understand. It also took me some time to understand this because usually we don't, I have never read about it before. So there are 3 stages of GAS. GAS, General Adaptation Syndrome. First stage is the alarm stage. So whenever there's a stress, okay, you get into alarm stage. It is an emergency response of the body in response to the stressor. Okay. Then there is a flight or a fight response. You know this happens because of adrenals, mainly mediated by the sympathetic nervous system, which is anxiety or fear, sorrow or depression, shock or confusion. You can have either or, either this or that. That's the fight or the flight. Okay. Fight means suppose you have a tiger in front of you. You go into alarm stage first, and then you realize that can you fight? Should you fight that tiger, or should you move away from that place? That is flight. Okay, fight or flight. That is what we decide in this alarm stage. And then you come to resistance stage. If that continuous stressor is present, body tries to resist the effect. It will try. Body will try its maximum to resist the effects. यहाँ पे क्या होता है, you'll have all kind of hormonal responses of the body which come into play. So initially what that whatever that alarm stage is happening is because of your sympathetic nervous system. And then in the second stage, where you have the resistance stage, that's where the hormones act. That's where your adrenals become more active. So your ACTH, adrenocortic tropic hormone, that's when that is activated, and you have cortisol secretion in the second stage of gas. This is a just basic diagram. And the third phase is the exhaustion phase. So we'll first finish that and then I'll show you the picture. But what happens is high level of cortisol in the blood for longer time can lead to immune suppression and high BP. That's why whenever you have extreme stress, अरे doctor बहुत stress है, especially most of the BP patients tell you. So one of the cause for having the sudden high BP or the sudden raise of 10 or 20 mm of that Hg of the BP is because of the stress. That's the level. That's the third level where you know whenever your cortisol raises, that is what is increasing your BP, and along with that, it will also reduce your immunity. And then finally, you come to exhaustion. You're fought now. Then at the last, you get exhausted. So first stage is alarm. Second stage is your resistance, and then third stage is your exhaustion. Exhaustion में क्या होता है? Inability to defend. You have tried. Body has tried defending now against that stressor. That continuous stressor is there. At one point of time, your body will give up, saying, I'm done. अब मेरे से नहीं होता. So that's your exhaustion stage. So inability to defend against the stressor develops here. Body's capacity to respond to the stressors is being seriously compromised. Person may become ill, can even die due to high cortisol. So very dangerous. This is what is your general adaptation syndrome. This happens in everybody. Okay, so stress is not good for you. Don't take stress. So general adaptation syndrome is identified by Hans Selye. It's our stress response system which defends or which becomes fatigue. So if you have a low stress, it's not a problem. But if you have a high stress, initially you have an alarm reaction. That's your phase one, alarm reaction. यहाँ पे क्या हो रहा है? Sympathetic nervous system is acting. Then you have phase two, which is resistance. The body tries to cope with the stressor. ठीक है, देखेंगे 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 करके body will be pulling it. That's when all your hormones act. Your ACTH gets activated. Cortisol is released. Okay, that this stage means there can be a slight increase in your BP. The immunity can go low. Okay, there might be immune suppression. But if that goes on for a while, the body gives up, saying that I am done. That's your third phase, which is exhaustion, which reserves are depleted. All our reserves are depleted. All the energy is gone. And what happens? Your immunity is completely low. You can develop infections. The person can die, or can die because of the high cortisol levels. You can have some kind of very high blood pressure that can cause immediate death of the patient. What are the functions? Coming back to liver, you saw where the liver is situated, right? The liver is majorly situated in the right hypochondriac region, or the right side or right upper quadrant of the stomach. So one of the functions is glucose metabolism. So after you've taken the food, that glucose conversion occurs in the liver. Okay. So after digestion, all that food which comes into your intestine, it's all reabsorbed. It goes into your portal system. पोर्टल वेन से जाता है लिवर को. लिवर में होता है मेटाबॉलिज्म एंड इंटॉक्सिकेशन ऑफ द टॉक्सिक थिंग्स. सो वहाँ पे ग्लूकोज इज कन्वर्टेड टू ग्लाइकोजन, एंड whenever the body requires, this glycogen is actually stored in the liver, and whenever the body needs it, this glycogen is again converted back to glucose. So glucose metabolism occurs in the liver. It's one of the functions. Either it can be glycogenesis. Genesis means you are generating glycogen. So glucose is getting converted to glycogen and stored as glycogen in the liver. Glycolysis. Lysis means breaking down. Glycogen is converted back to glucose by breaking it down. And there's something called gluconeogenesis. यहाँ पे glucose is synthesized from non-carbohydrate substances such as protein and amino acids. So glycogen is not converted to glucose here. carbohydrate substances such as protein and amino acids are converted to glucose. That's called gluconeogenesis. Neo is new. Newly you're generating glucose. Okay? And then ammonia conversion also takes place. Why do all alcoholics develop hepatic failure? Because ammonia conversion takes place here. Okay. Protein and amino acid metabolism is what leads to ammonia generation. Okay. Liver converts this highly toxic ammonia to urea, and that urea is secreted into back into the system, through which it will come out through your urine. You're urinating out that excessive urea. So this conversion of ammonia to urea. Ammonia is toxic to our body. It has to get converted to urea. That occurs in liver. So I was telling you bilious, non-bilious vomiting. So usually a non-bilious vomiting is like whitish or pale yellow in color. But if you have all these colors, especially from like all this 3, 4, 5, 6, 7, 8, all these are like bilious vomitings, and this is how it looks: dark green vomit. It's a bilious vomit. What is protein metabolism also occurs in liver, just like glucose metabolism. Liver synthesizes all plasma proteins except gamma globulins, such as albumin, alpha and beta globulins are very important. Albumin is very important. Alpha beta globulins are very important to form your hemoglobin. Okay. So, except gamma globulin, remaining all the plasma proteins are being synthesized in the liver. Fat metabolism also occurs when glucose is not available. What happens if you're starving? If the patient is starving, is not eating anything, there is no intake of carbohydrates, and all the glycogen stores are depleted. There is no glycogen available for conversion to glucose. Whatever fatty acid is being stored now, or the fats, those are broken down to produce energy. Okay, so what happens in starvation is all your fatty acids are being used. Vitamin and iron storage also occurs. Your B12, once all the stores of B12 are completed, like you have full stores of B12, that stays in your liver for at least 3 to 4 years. And your folic acid stays in your liver for at least 3 to 4 months. So after that, if there is excessive usage, all that stores also can get depleted. So you have to keep taking on and off B12 and folic acid, especially B12 in vegans. So, vitamin and iron storage, liver stores large amounts of ADEK. What is ADEK? ADEK are all fat soluble vitamins. Okay. All the B vitamins are water soluble. So, ADEK and vitamin B12. It is also stored. Even folic acid, B9, is also stored, along with minerals such as iron and copper, also stored. Drug metabolism also takes place. I told you intoxication has to occur. All that excessive drug is being removed by the liver. So liver is also a major site for drug metabolism. Okay? It's called first metabolism, yeah? Especially if you're taking drugs orally. Bile formation also occurs. Hepatocytes synthesize bile and store it in the gallbladder. All that hepatocytes will synthesize bile. The storage place is the gallbladder. Bile salts are formed from cholesterol. So cholesterol is what which forms the bile salts, and this bile salts and bile is very important for fat metabolism. GERD, coming back to it, I think we've already finished this, but I'll just read through it. Management is dietary modification. Okay. Encourage low fat diet, avoid caffeine, avoid excessive of tea and coffee, avoid tobacco, smoking, avoid beer or carbonated beverages and milk. Okay. Avoid excessive of alcohol, avoid eating and drinking 2 hours before the bedtime. You do it 3 to 4 hours. Usually it takes at least 2 to 3 hours for the digestion to occur. So during that time, if you're staying active, you can prevent this problem. But if you eat and immediately go to sleep, एक तो you'll put on weight. Second thing, if people have GERD, it will worsen. Avoid tight fitting clothes. Elevate head end of the bed and elevate upper part of your body, that's your shoulders, over a pillow. Okay, you want to keep it as up as possible so that reflex doesn't occur. But if you're lying flat, reflex can occur. It's just the gravity acting here. Pharmacological management is, I've already told you, it's H2 histamine receptor antagonist that decrease. I think I told you H1, so it's H2, sorry. It's H2 histamine receptor antagonist, which reduce the acid production. Example is cimetidine, ranitidine. Okay, these reduce the gastric acidity. And then you have proton pump inhibitors. This also reduce the acidity, and they also increase the lower esophageal sphincter tone. They'll tighten that lower esophageal sphincter tone, which has become lax. For that, you need pantoprazole. Everybody knows this. Pan. Everybody uses it. Pantoprazole, omeprazole, omaze. Okay. Gastric emptying is done by, if you have faster gastric emptying, that food will not stay in your stomach for very long time, then you can prevent the reflex from happening. So one of the prokinetic which causes increased peristalsis is Riglan. Okay. Then you have surgery. You do something called as fundoplication. This is wrapping of the gastric fundus around the sphincter. The sphincter is what there is a problem. So you'll wrap this stomach part of the cardia of the stomach around, or stomach fundus around this lower esophageal sphincter. ऐसे करके. That is called fundoplication. The liver is situated mainly at the right hypochondrium, extending through the epigastrium and reaching the left hypochondrium. I've already told you that. I've showed you in the picture. Then Kapha cells, I've told you the policemen, the macrophages of the liver. In liver, bacteria that have found their way into the portal circulation are destroyed. So all that bacteria which has entered from the intestines and all that area, which enter into the portal system, all this portal venous blood is all rich with nutrients, rich with bacteria which is coming from the intestine. They're all killed by the kapha cells. The minerals and the vitamins are absorbed and they're sent back to the systemic circulation, but any kind of bacteria which enter to the portal system are destroyed in the liver by these kapha cells. Bile secretion, hepatocytes secrete 500 to 1000 ml per day. That's like half to 1 liter per day. Bile is also called pseudo digestive juice because it does not contain any digestive enzymes. Bile के अंदर digestive enzymes नहीं, it has bile salts, it has bile pigments. There are no digestive enzymes, but it helps in metabolism of the fat. So it's called pseudo digestive juice because there are no enzymes. This is a pear. Okay. This is how the gallbladder looks. Imagine this as a cystic duct entering into the common hepatic duct. It's a pear-shaped organ of 7.5 to 10 centimeters in size, and the capacity of the gallbladder is 30 to 50 ml. Gallbladder is connected to the common bile duct by cystic duct. So common hepatic duct is coming from up. The cystic duct comes and joins it, forming a common bile duct. And this common bile duct, along with the pancreatic duct, opens into the ampulla of fat, finally opening into the duodenum, which is a part of the intestine. What are the functions of gallbladder? It is to store bile. Whatever hepatocytes have produced, वो जाके कहाँ पे store होते हैं? It gets stored in the gallbladder. It's like a sac-like thing. ठीक है? Water content of the bile is absorbed by the gallbladder wall during storage, and the bile becomes more concentrated. So concentration of the bile is a function of the gallbladder. All it is getting mixed, all that water and bile which has the bile which is being produced by the hepatocytes along with water, everything gets stored in the gallbladder. All that excessive water is being absorbed off by the gallbladder, and whatever bile is in the gallbladder becomes more concentrated, 5 to 10 times. It has both endocrine as well as exocrine functions. Okay, so secretion of pancreas. We're coming to pancreas. I'll show you a picture how pancreas is like. It's a leaf-like organ. Okay, it's just below the stomach, just below the greater curvature of the stomach. Okay, it has both endocrine and exocrine functions. Secretion of pancreatic juice is what occurs via the pancreatic duct, which represents the exocrine. So, secretion of pancreatic juice for digestion purpose is the exocrine function. And alpha cells of the pancreas produce glucagon, and beta cells, there's different cells in the pancreas. It's a little bit like pancreas has a lot of function. Even though it looks very small, the different parts in the pancreas and each part has its own function. A little bit of pancreas is retroperitoneal, a little bit is intraperitoneal. So there's a lot to do in pancreas. We'll just discuss whatever sir is given here. Alpha cells, there's one type of cells called alpha cells, then there is beta cells. Alpha cells produce glucagon. Beta cells or of pancreatic islets or islets of Langerhans. That is what which produce the insulin. So if anybody asks you insulin kahan se? Many of you know that it is produced by pancreas, but which cells? Beta cells, also called as islets of Langerhans. This is what produces the insulin. Pancreatic enzymes are whatever the pancreatic juice is there, in that you have these enzymes which help in metabolism of the proteins. So you have trypsin, you have chymotrypsin, okay? You have amylase and you have lipase. So many of you know whenever you have a pancreatitis patient, serum amylase karo, serum lipase karo, most of the doctors give you commands, right? Because these enzymes are being produced by the pancreas. So, ये कर रहे हैं. If that is highly elevated, it indicates that there is pancreatitis. So you have trypsin, chymotrypsin, you have amylase, and you have pancreatic lipase. So trypsin is what helping in protein metabolism. Chymotrypsin is also helping in protein metabolism. Then there's one more thing called carboxypeptidase. नाम में ही है, peptides are broken down. So even that helps in amino acid, or we can say protein metabolism. Then you have pancreatic amylase and lipase. This amylase and lipase are what breaking down fats. So amylase is breaking down carbohydrate fats, and lipase is breaking down this cholesterol cholesterol and phospholipids. Okay. So this is your pancreas. This is how it is situated. Imagine that your stomach is coming like this. यहाँ पे you have your uh, pyloric area. Just imagine this is the body, this is the and यहाँ पे एक जगह पे आके your ampulla of bladder is there. This pancreatic duct lies like this. So vessel leaf like all that comes and gets collected, and the side से pancreatic duct आता है, both combine and open in the ampulla of bladder. What are the diagnostic tests for liver? So everybody knows liver function test, liver function test, liver function test. Everybody knows. So it is the blood serum test. So you're taking blood, and the serum is what is being seen for varied things. You have a lot of things when it comes to LFT. You check the liver enzymes, a lot of things, bilirubin, okay, and the unconjugated, conjugated bilirubin. All these things are being checked by LFT. It is a blood serum test which assesses liver functions in terms of serum enzymatic action. And then there's something called liver biopsy. You can also do a liver biopsy percutaneously. So you have a liver biopsy needle which will pass into the liver, and you take a small portion which is sent for biopsy. Remove a small amount of liver tissue, usually through needle aspiration. That is, with all this, what are you actually monitoring? LFT में क्या कर रहे हो? You're checking for serum enzymes like alkaline phosphatase, okay, lactic dehydrogenase, aminotransferases, albumin, globulin, bilirubin, ammonia. All these things you're checking in the LFT. So this is the thing which we do for liver biopsy. So you're passing this needle into the liver, and a small piece is being aspirated. Okay, this is the liver biopsy needle. Send that for testing. So removal of a small amount of liver tissue, usually through needle aspiration. You'll do coagulation studies to obtain before puncturing with a needle. You have to do a coagulation studies because if this patient have any kind of bleeding tendencies, then you're causing more problem to the patient. So you'll do a coagulation study before. Key clotting time, bleeding time, subnormal, like in your APTT, PTINR is all normal or not, and then you can puncture and you can do this, because in the way if you end up touching any kind of a major vessel, then it can bleed like hell, and you don't want that. And then before doing a biopsy, obviously going to take a written consent. Without बिना consent के तो आप छुपाओगे नहीं ना. So you're going to take a consent, and then you can do a liver biopsy. Then you make the patient to lie left lateral or supine position during the procedure. Left because right side is your liver, right से निकालना है, or you make the patient to sleep supine with hand up like this. Immediately after the procedure, you'll place the client on the right side and place pillow under the right coastal margin. This is to prevent bleeding. Simple. You're causing a pressure over the site where you have punctured. So you're causing a pressure will lead to hemostasis. Instruct the patient to avoid coughing or straining because that can lead to more bleeding. So I've told you pancreas is both endocrine and exocrine. Exocrine ज़्यादा है 99%, endocrine कम है 1%. ठीक है. Beta cells or islets of Langerhans is what acts as the endocrine. Insulin produce हो रहा है ना, so that is what is acting here. It is especially concentrated in the tail portion, last portion of the pancreas. वहाँ पे is where the insulin is being produced. You need insulin for your sugar metabolism. The opening of the pancreatic duct into the duodenum is at the angle of Vater. Majority of pancreatic cancer arises at the head. So tail corner में है, tail से ज़्यादा insulin आ रहा है. You have more concentration of beta islet cells there, Langerhans cells there. So वहाँ पे is that tail is the place where the insulin is produced. But if you talk about CA carcinoma pancreas, it's more common in the head portion of the pancreas. What are the disorders of hepatobiliary system? Coming back to hepatobiliary system, any kind of obstruction can lead to jaundice. When the bilirubin levels in the blood are elevated, all the body tissues such as sclera, the skin will become yellowish or greenish yellow. This discoloration occurs especially if the bilirubin levels are more than 2.5 milligrams per deciliter. This is how the patient will look, all yellow. You can see this yellowing of the skin and yellow sclera. This is how this is severe jaundice. So you can see complete yellow patient. Okay. Then you have in jaundice you have three types of jaundice. One is hemolytic, second is hepatocellular, and third is obstructive jaundice. What is hemolytic? Name itself says there's breakdown of the RBCs, hemolysis. So hemolysis is destruction of the RBCs, results in increased bilirubin. Whenever the RBCs are broken down, bilirubin is released. This increased bilirubin in the blood causes hemolytic type of jaundice. Damaged hepatic cells क्या होता है? That is hepatocellular. Suppose hepatocellular में क्या होता है? That the cause is the liver. So liver is having some kind of an issue. So liver में क्या होता है? All this bilirubin is getting converted from unconjugated to conjugated. No? Conjugated is the most absorbable type. Again, it is released back into the systemic circulation to be excreted as urobilinogen in the urine and the feces. That's what which gives the color to the urine and the feces. So liver में ये नहीं हो पा रहा. What happens if you have more damaged liver? If there is cirrhosis of the liver, if there is any kind of pathology involving the liver, they're not able to clear this bilirubin in the blood. That can lead to hepatocellular kind of a jaundice. And then there is obstructive. Any kind of obstruction in that level, either at the cystic duct or at the common hepatic duct, anywhere in that area can lead to obstructive jaundice. So impaired excretion of the bilirubin due to mechanical obstruction of the biliary tract, that is obstructive jaundice. Liver is unable to conjugate excessive bilirubin from hemolysis. So whenever you have hemolysis, दोनों रहते हैं. You have both conjugated and you have unconjugated. Okay. Extrahepatic obstruction में क्या होता है? Whenever there is obstruction outside the liver, it occurs due to occlusion of the bile duct by the gallstones. So if you have any kind of gallstones forming in the cystic duct, that can cause obstruction of the cystic duct, that all that bile which is there in the gallbladder cannot come out. So इसमें क्या होता है? You have more unconjugated. So you have elevated unconjugated bilirubin in obstructive jaundice. And what happens is abnormal prothrombin time. If you have an abnormal prothrombin time and it is not corrected with vitamin K, it implies there is an intrahepatic obstruction resulting from the stasis of the bile within the canalicula. It is seen in patients with hemolytic transfusion reaction. So if you have an abnormal prothrombin time, you're trying to give vitamin K, it's not getting cured, then you have to think about the intrahepatic obstruction. There's some kind of obstruction inside the liver. So in these patients, prothrombin time is elevated. Okay, it is seen in patients with hemolytic transfusion reaction and other hemolytic diseases. Mainly 50% elevated levels of conjugated bilirubin is seen in serum. That is in hepatocellular and hemolytic diseases, not obstructive. In obstructive jaundice, you see more unconjugated bilirubin. This is not getting converted. No, it's not even coming to the liver. Normal prothrombin time is abnormal prothrombin time corrected with vitamin K. If that normalizes, then that is not the reason. Hemolysis is not the reason, or transfusion reaction is not the reason for that kind of an issue where it gets corrected with vitamin K. Coming to portal hypertension, so I told you all this gut and all they drain into a venous system called portal venous system, and that finally goes to liver, where all that metabolism undergoes, and any kind of toxins are removed by the liver. Okay, so if you have any kind of obstruction in that tract, okay, if there is a issue with liver, बीच में पूरा portal vein can get obstructed, or any kind of issue with the obstruction in the portal system, that will cause raised um, pressures in the portal system, leading to portal hypertension. So obstructed blood flow through liver resulting in increased blood pressure is known as portal hypertension. And इसमें you will have splenomegaly. Spleen will get increased because even splenic vein is coming and draining here. Okay, any kind of obstruction, spleen will sense it and it will become more fat because it's unable to drain. Consequences of portal hypertension also includes ascites. All that excessive fluid has to go get accumulated somewhere. No, it comes out through the portal system and causes ascites. Or esophagus, lower part of esophagus also drains into this portal system. Even that can develop varices. Varices means varicose veins in the esophagus. So this is the liver. There is some kind of an issue. So pressure is occurring here. This portal vein is not able to, drain properly into the liver. Unless it drains, that's when yahan se systemic circulation starts, and that finally drains into SVC, that is superior vena cava. So any kind of issue here, any kind of obstruction here can cause raised tension or raised blood pressure in the portal system. So spleen will get enlarged, and because even lower part of the esophagus is being drained, वहाँ पे varices can develop. Can you see here dilated veins, bluish dilated veins? These are the esophageal varices which can bleed if the patient has excessive straining or any kind of vomiting, can rupture these veins, and or excessive hypertension can also in the portal system can also rupture these veins, and that person can have uncontrolled bleeding. Yesterday we were talking about Sengstaken Blakemore tube. That tube can be used here to control the bleeding. Okay, the esophageal balloon of the Sengstaken tube can be used here to cause pressure over these bleeding varices. What is ascites? Ascites is nothing but fluid accumulation in the abdominal cavity. Fluid moves from vascular system into the peritoneal space. Due to first reason is one of the reasons is electrolytes. So if you have sodium and water retention, all your body swells up. Ascites also can occur. Increased intravascular blood volume. So there's too much of blood intravascularly, even that can seep out and cause ascites. Decreased albumin synthesis. If there is any problem with the liver, decreased albumin, even that can lead to retention, fluid retention, and causing ascites. Signs and symptoms क्या रहता है इसमें? Because of increased abdominal girth, abdomen looks bloated. Okay, if it is too much of ascites, the skin over the abdomen will look shiny, like how the balloon looks, and all the veins or the venules over the skin become more prominent. The patient can the patient will look as if he's gaining weight because of the fluid retention, rapid weight gain. The patient can have shortness of breath because all that excessive pressure in the abdomen is causing pressure on the diaphragm, leading to reduction of the activity of the lungs, causing pressure over the lungs. So that patient can develop shortness of breath. That is one thing. Second thing is even excessive fluid accumulation can occur around the heart in the pericardial region or in the lungs in the pleural cavity if albumin, increased intravascular or sodium in water retention is there. Even there it can occur leading to SOB, shortness of breath. Patient can have stria or stretch marks and distended veins over the abdomen. What do you do? How do you manage? Sodium restriction. Salt come cover. You reduce the amount of salt. Diuretics to push that excessive fluid out into your urine. Paracentesis. Paracentesis is you introduce a needle into the peritoneal cavity through your skin, abdominal skin, and you attach it to a collecting jar outside, jahan pe you have this collection of the stock. You're removing, like you're just removing that excessive fluid. It's called paracentesis. This is how you do paracentesis. You're attaching a needle. There is this tube which is entering into this jar, and इसमें acidic fluid is getting accumulated. Okay. How much of acidic? All this straw colored fluid is acidic fluid. Patient is placed in supine position during the procedure and slightly rotated to the side of procedure. Pani jahan pe hai, wherever the water is, if you move to that side, all that water will get accumulated to that side. So it is all getting accumulated to one side. So wahan pe you give a small needle puncture, and that's how it's get collected. This is to minimize also the risk of perforation. Left lateral approach is preferred because right side way you have your cecum sitting just immediately there. So you don't want to do any kind of puncture to the cecum. So imagine if there's a lot of fluid inside, all your organs are happily floating in it. So you might enjoy the cecum wherever you're doing that. The different areas for the needle puncture, and एक जगह पे cecum जहाँ पे रहता है right side पे, if you puncture that area, you might cause some kind of damage to it. So you mostly prefer the left lateral approach. What are esophageal varices? Esophageal varices, I just told you, you are seeing it in portal hypertension, dilated tortuous veins, nothing but varicosity of the esophagus found in the submucosal layer of the lower esophagus. Cause, in case of portal obstruction, blood from the intestinal tract and spleen seek a new pathway via esophageal plexus. So, I didn't tell him that एक जगह से what happens is there is an obstruction at the liver. So some way or the other the blood has to go. Na? So all that excessive blood goes and forms some kind of venous plexus around the esophagus. That is why you get esophageal varices. So I'll read this line for you again. In case of portal obstruction by the liver, blood from the intestinal tract and spleen will seek a new pathway via esophageal plexus. That's why the veins in the esophagus get dilated. All that blood, excess blood is being diverted towards the esophagus. Esophagus plexus is not elastic, so it becomes more tortuous, fragile, and bleeds easily. Clinical manifestation is hematemesis. They'll have, if they're vomiting, they can vomit blood because of this breakage, or there's bleeding inside and it's going down towards your fecal matter. It's getting mixed up with the fecal matter, it leads to melena. And there can be symptoms of shock because of excessive blood loss. That patient can go into shock. So in paracentesis, what are you doing? Rapidly you're removing fluids from the abdominal cavity. But you're supposed to do it gradually. But what if you do suddenly? What can happen? Sudden difference in pressures. That patient can go into shock. So you have to be very careful that decreased abdominal pressure can cause vasodilatation and sudden shock in that patient. So you have to avoid that. The paracentesis has to be done in a gradual way, but not a rapid way. Okay. What is icterus? It's nothing but the term for jaundice. It's a sign that is present that the patient is experiencing hepatic coma. And clay colored stools is a sign of obstructive jaundice. Clay matlab matti, clay untadi kada. Clay matlab multani mitti like. Okay, I'll show you. I have a picture. So it's like whitish gray. Okay, it is not that urobilinogen, that pigment which is supposed to come from bile, is not able to enter into the systemic circulation. So what happens? It is not entering into the blood lumen, into the lumen of the intestines. Neither it is getting excreted into the urine because this obstruction, bile is not being secreted. So all that, and because there is no pigment going into those parts of the body, the urobilinogen, which is coming from the bile, which has to stain this species and also stain the urine, उसके absence के वजह से all that urine will be pale and the feces will look clay colored. There's no pigmentation. That's why it look clay colored. Then you should suspect, oh, this person might be having an obstructive jaundice. Varicose hemorrhage is the most common complication associated with portal hypertension. The shades, brown is a normal shade. Here you can see this whitish or clay colored. This is how the feces will look if that patient has obstructive jaundice. Red kind of a stool you will see if you have frank bleeding, especially from hemorrhoids, external hemorrhoids. Frank matlab fresh bleed. If you have bleeding occurring somewhere inside and then slowly coming and getting mixed up with the stool. This is how the stool will look. This is called melena or black colored stools. What is the portal hypertension management? It's a hypertension. You're supposed to decrease that. You'll give vasopressin, somatostatin, octreotide. These are the drugs used for to decrease the bleeding. Balloon tamponade, I've already shown you Sengstaken Blakemore tube. That's the tube you cause dilatation in the esophageal area and you're causing the pressure over those varices leading to hemostasis. It is done with Sengstaken Blakemore tube. Endoscopic sclerotherapy, you will inject in that varicose area which is bleeding, you will inject one sclerosing agent. That will again cause completely reduction in the bleeding. It undergoes sclerosis and that bleeding stops. That's called endoscopic sclerotherapy. Sclerosing agent is injected into the bleeding varices to promote healing. And then you have esophageal banding. Esophageal banding therapy and variceal band ligation. You can ligate that area, whichever area is undergoing bleeding. If you ligate, you're stopping the bleeding. So elastic rubber band is slipped over through endoscope and the bleeding varices, which causes over the bleeding varices. So once the band is there, it causes necrosis and finally leading to stoppage of the bleeding because it's stopping the blood flow to that particular area. Next, transjugular intrahepatic portosystemic shunt tips. This is also one of the methods used. It's an intrahepatic shunt which is created between portal circulation and hepatic vein. Directly will cause a shunting. Okay, transjugular intrahepatic portosystemic shunt. It's a surgical. It's kind of a surgical management. Hmm. And one more thing you can do with in surgery is you can ligate these bleeding varices, or you can do a esophageal transection and devascularization. If the patient is about to undergo shock or there's excessive bleeding, uncontrolled bleeding, then you can transect that part of the esophagus and you can do this devascularization. This you're supposed to understand. Tips I will not go very depth into it. काफी depth है तो this much just understand the tips is being used here for portal hypertension, transjugular intrahepatic portosystemic shunt. You're causing a shunt. You're just like a bypass surgery. Okay. सर्जिकल बाईपास प्रोसीजर्स में क्या रह सकता है इसमें यू आर डूइंग again you're doing a bypass here. These procedures help to drain a portion of the portal blood and thereby help to reduce the portal pressure. You can also do splenorenal shunt. So you can directly attach the spleen to the renal system. Mesocaval shunt. You can also do portocaval shunt. Directly or attaching it to the vena cava. Shock, again, what is shock? Shock is a condition in which systemic blood pressure is inadequate to deliver oxygen and nutrients to cellular function and vital organs. It is an acute medical condition associated with reduced perfusion to the body tissues. So, shock is a condition in which the systemic blood pressure, not the portal, systemic blood pressure is inadequate to deliver oxygen and nutrients to the cells, all the cells around and vital organs. को ये blood supply नहीं दे पा रहा है, oxygen नहीं दे पा रहा है. It is an acute medical condition. It's associated with reduced perfusion to the body tissues. Etiological classification, we have different types of shock. So one is hypovolemic shock. The name itself says volume is less. And cardiogenic. Cardio matlab it's involved with heart. And third one is circulatory shock or disruptive shock. So we'll just finish this sense taken tube and I'll take up the remaining part tomorrow. So sense taken Blakemore tube में क्या है? Sense taken I already showed you. It has 3 lumens. 3 lumen रहता है. Okay. You have ports for gastric. You have one port for gastric, one port for esophagus. This is how the tube looks. This is the esophageal one. This is the stomach wala. Okay. So you have here three tubes, three lumens, ports for gastric and esophageal balloon and gastric aspiration. If you're supposed to aspirate, you have one more port for it. Then you have something called Minnesota tube, which has four lumens. So I told you Sengstaken Blakemore, it has undergone some kind of variations. So if Minnesota है तो उसमें चार रहते हैं. Sengstaken में of three. यहाँ पे दिख रहा है ना 1, 2, 3. 1, 2, 3. Okay, in Minnesota you have four lumens and you have two balloons. And extra thing in Minnesota is you also have an esophageal aspiration in addition to the gastric aspiration port. Purpose of these lumens are you can aspirate from the stomach, which is gastric aspiration, or from the esophagus, or you can do a gastric balloon inflation, or you can do a esophageal balloon inflation. You're using this Sengstaken tube especially in esophageal varices. So stomach balloon is inflated with 100 to 2 ml, 100 to 200 ml of air. X-ray confirms the position of the gastric balloon. Then the gastric balloon is pulled against the cardiac part of the stomach. If it is nicely inflated, वो उसको pull करके वो नहीं आएगा क्योंकि वो inflate हो चुका है ना अभी नहीं आएगा. Irrigation of the tube is done to detect bleeding. If return from irrigation is clear, irrigate करके you are taking out the fluid and checking. If the irrigation is clear, the esophageal balloon will not be inflated. But if the bleeding is present, then the esophageal balloon will be inflated. Pressure in the esophageal balloon is 25 mm Hg and pressure in the gastric balloon is 40 mm Hg. Once the bleeding varices stop, I already told you the first balloon to inflate is the gastric balloon and the first balloon to deflate, removing of the air, is the esophageal balloon. Once the bleeding varices stop, first esophageal balloon will be deflated. After several hours without bleeding, then the gastric balloon will be deflated and then you remove out the tube. If several bleeding free hours are there, then the tube will be removed. Okay. Diagnosis is by CT, MRI, aspiration, and analysis. Okay, this 11 and 12 point doesn't belong to the Sengstaken tube. It belongs to liver abscess, which we'll be doing it tomorrow. Yeah, this I'll be doing it tomorrow. We'll have to add few more pictures to it so that it becomes easy. So if you have any questions, please do ask. Ramya, hi. So I'll be answering your questions. I'm sorry I didn't check your comments. Mm. Yeah, so milk also causes GERD. Milk and milk products can also lead to GERD. It can increase the acidity. But according to Ayurveda, I have heard that taking milk early in the morning, like little glass of cold milk, helps in acidity. But it is not recommended for GERD patients, and because milk can cause acidity. Just remember that part. Okay. I can't see your comments, Ramya, when I am taking the class. So I usually take the comments at the end of the class. You'll have to wait for me, okay? Especially when I am doing the PPT, my whole screen is occupied by the PPT, so I can't really see your comments. So this is my answer to you, okay? It is not advisable to take milk in GERD cases because milk can lead to acidity leading to GERD. It will worsen the GERD. I hope this is clear for you. Okay, guys.